Hello, you are most welcome, ladies and gentlemen, to the Understanding Spirit of Anatomy on Tuesday Night Anatomy with Daniel Okwan. Now, today's section is going to be on the abdominal wall. So, we're going to look at both the anterolateral abdominal wall as well as the posterior, abdominal wall. So, without much ado, let's quickly, go through this. So, begin with question number one. Question number one says, which of the following is false? Option A says, below the umbilicus, the superficial fascia of Campa is reinforced by a deep membranous layer of scapa. Now, this is a very true statement. Now, bear in mind that the superficial fascia is just like any superficial fascia that we have in the rest part of the body. In that, yes, you know that we have skin, and the skin is made up of course, epidermis, and of course, dermis. And below this dermis will be a layer of hypodermis. And hypodermis is the superficial fascia that we're talking about. And it's actually fatty, or that's what we call the subcutaneous tissue. Okay, having a lot of these kind of adipocytes. But what happens is that, yes, above the, umbilicus, what happens is that all the area will also have this superficial, fascia being made of a single layer of campus. That's only fatty. But below the umbilicus, okay, is when, because below the umbilicus, people tend to accumulate a lot of fat there, and therefore the tendency that below the umbilicus, okay, there could be that kind of pendulous movement, such that that area may sag, and therefore God in his own wisdom reinforced the superficial fascia of campus below the umbilicus with a deep membranous layer of scapes. So remember, if the question says yes, normally we expect that superficial fascia is made up of a single layer except below the umbilicus. So please get to know that. Option number B says linea semilunaris signifies the point where the fleshy fibers of the trilaminal muscles become aponeurotic. This is also a very true statement. I will show you pretty soon. But get to know that yes, on the anterolateral abdominal wall, we are going to have three flat muscles, and they form this trilaminar muscle. Now, what happens is that from the lateral aspect, they're actually, going to be fleshy fibers, but as they come, okay, toward the anterior aspect, they become aponeurotic, and this aponeurotic, nature begins at the level of, the mid-clavicular line. I'll show you that. Now, option C says the only trilaminar muscle that inserts on the outer lip of the iliac crest is the obliquus externus. Okay, so this is actually a very true statement. Now, remember, all muscles, and for that matter, all these three, flat muscles of the anterolateral abdominal wall that we are talking about, of course, namely external oblique muscle, yes, internal oblique muscle, and then of course, transversus abdominis muscle. Remember that if you hear obliquus externus, we are still talking about external oblique muscle, okay, of the abdomen. Now, this muscle is the only muscle which inserts on the iliac crest. Rest of the muscles will actually take origin from what we call the iliac crest. So this is a very true statement. Now, option D says the flat trilaminar muscles of the abdomen are generally innervated via, nerve levels, spinal nerve levels T7 to, of course, T11, T12, and L1. This is actually a very true statement. Of course, we will get to know that, yes, the thoracoabdominal nerves, will actually be, innervating most of these muscles together with, of course, the subcostal nerve, as well as, of course, the, the iliohypogastric and, of course, ilioinguinal nerves, which are branches or terminal branches of what we call the L1 ventral ramus. Okay, so we look at that. Now, option E says the rectus sheath generally is formed by the aponeurosis of the trilaminar anterolateral abdominal wall muscles and contains the rectus abdominis muscle, pyramidalis muscle, and only the inferior epigastric vessels. So this is where the problem is. Yes, remaining statements are true. Yes, rectus sheath is formed by the aponeurosis of the trilaminar anterolateral abdominal wall muscles. No problem. Yes, contains, so as part of the contents, we have what we call the rectus abdominis muscle. We have the pyramidalis muscle at the lower aspect. No problem with that. But the next statement, which says only the inferior epigastric vessel, it's not only the inferior epigastric vessel, because we also have what we call the superior epigastric vessels. Even apart from that, we also have, of course, even the subcostal nerve will become even a content of it. So we have to actually understand this one, even together with some other arteries or vessels. So just by way of justifying these things, yes, get to know that here we have the skin. Okay, skin. The skin is made up of course epidermis and dermis. Epidermis being the epithelial lining, epithelial layer, and then dermis being the connective tissue. When you look at skin, we actually learn a lot about that. Now beneath that will be a layer of fatty tissue, just like what we find in any other place around the human body. Is going to be a fat layer, okay, and that is what we call the campus fascia. Campus fascia. So the campus fascia will be everywhere, okay, above what we call the umbilicus, okay, everywhere, okay, above the umbilicus we are going to have only campus fascia. But below the umbilicus, apart from this campus fascia, we will have a deep membranous layer of scapes, and that's the scapes fascia, okay, scapes fascia. And then below that we are going to have the trilaminar muscles, okay. So there's the, of course, from outside to inside we are going to have the external oblique muscle, we are going to have internal oblique muscle, and then of course we have the transversus abdominis muscle. And then of course beyond that we are going to have what we call the transversalis fascia, being the endo abdominal fascia. And then of course we are going to have a layer of fatty tissue, being the extraperitoneal fat layer, because we know that moving away from this side we are going to the parietal peritoneum, so it's outside the peritoneum, and therefore we are going to call it extraperitoneal fat layer. And of course there will be a peritoneal cavity, and of course visceral peritoneum will be there. And of course the peritoneal cavity you are going to have of course peritoneal fluid. When we look at the greater sac of the abdomen, we actually get to understand all these things. Now get to know that yes, we are having in the wall, anterolateral abdominal wall, we are having two fat areas. Now this is quite thicker, and that's the campus fascia, and this is the extraperitoneal fat layer. Now individuals who tend to put on a lot of weight, usually it is this side which actually accumulates with a lot of fat. Okay, so as you gain more weight, then the thickness of this campus fascia actually increases. Okay, rarely does this extraperitoneal fat layer increase in thickness regarding the fat content, although it may increase, but this one is the one which will almost always increase. The superficial fascia of campus. Okay, this is the one, and that is why some females may want to, if they tend to accumulate a lot of fat in the abdominal area, then they will go to what we call lipectomy or liposuction, so that this fat, okay, too much fat in the superficial fascia could be suctioned and of course put in places to endow, of course, mainly their gluteal region, of course even their breast areas. So this is what you have to actually know, so that yes, we can only find two layers of the superficial fascia below the umbilicus, the campus fascia and scapes fascia. Yes, by way of some surface anatomy, okay, this is the abdomen, okay, this is the abdominal area. I'll show you the 9 regions of the abdomen in our next video, where we look at the various viscera. You have to know those ones. Now please get to know that yes, by way of this side, okay, we're going to have the sternum, and therefore the xiphoid process will be related here, okay. And then of course we know the ribs are also there. So by way of surface anatomy, okay, as I run my finger or my pointer this way, then what happens is that we appreciate what we call the costal margin. The costal margin will be there. Now you get to know that over here there will be some straight muscles in there. There's the anterior abdominal wall. There will be straight muscles in here, and these straight muscles represent what we call the rectus abdominis muscle. Okay, rectus abdominis muscle, one on the left side and one on the right side. But this rectus abdominis muscle is actually interrupted, okay, by some tendon like structures, which we call them tendinous intersections. Now get to know that the left rectus abdominis muscle, the right rectus abdominis muscle will be separated in the midline by what we call the linea alba. Now this linea alba will be a very important insertion point for all 3 trilaminar muscles of the anterolateral abdominal wall. I'll show you that. Okay, so that's the linea alba, will be here. Okay, now you get to know that from the anterolateral abdominal wall, the muscles, okay, as you move laterally, as you come laterally, what happens is that the muscles are actually fleshy. You can see the fleshy fibers, but at the level of the mid-clavicular line, now this is the clavicle, okay, this is the clavicle. At the level of the mid-clavicular line, okay, we are going to find this linea semilunaris. Now, this linea semilunaris represent the point where this fleshy fibers, okay, of the, trilaminar muscles, okay, flat muscles of the anterolateral abdominal wall, will now change to become what we call aponeurosis. So aponeurosis, simply, they are just some form of tendon, okay, that we describe them as being flat, broad, and glycerin. Okay, so those tendons will be here. Why are they coming this way and then forming this kind of, flat, being this kind of aponeurotic, structures? Because they are going to actually form some kind of, they are going to decusate, actually crisscross, and then form some kind of, sheet for this, for these, rectus abdominis muscles. Okay, and that is what we call the rectus sheet. I'll show you that. So what I mean is that the fleshy fibers of the trilaminar muscles of the abdomen will be transformed into aponeurotic forms, okay, beginning at the level of the mid-clavicular line. So I told you that yes, the external oblique is the only muscle which actually inserts on what we call the outer lip of what we call the iliac crest. But let me show you actually the attachment of this iliac crest, of this external oblique muscle. Now the external oblique muscle, now you can see these are the ribs. Now there's rib 7, so it means that there's rib 6 over here, there's also rib 5. So all the way from rib 5 up to rib 12, actually, rib 5 up to rib 12, actually the external surfaces of these ribs, of rib 5 to rib 12, will be the origin of what we call the external oblique muscle. Now look at how the fibers of the external oblique muscle, it's like putting your hands in your pocket. So the external oblique muscle fibers actually run, inferomedially. So the fibers of external oblique muscle run inferomedially to insert on what we call the outer lip of what we call the, iliac crests. Even apart from that, it is going to insert in the linea alba. I told you that the linea alba is going to be a common insertion point for all these trilaminar muscles of the abdomen. Now, get to know that, yes, the lower fibers of what we call the external oblique muscle actually become what we call, give rise to this ligament, okay, in the, groin area. And the ligament is what we call the inguinal ligament. It therefore tells us that, yes, the external oblique also have some attachment by way of, insertion in what we call the, the lower aspect of what we call the pelvis. So that, yes, it's also going to have some attachment to what we call the pubic tubercle, as well as, iliac crest, iliac tubercle, iliac crest actually, yes, we've seen that one. So as well as, of course, pubic, tubercle, actually pubic tubercle. So that is what, we are going to see regarding, of course, the insertion of what we call the, external oblique muscle. Now remember that the external oblique muscle, yes, will actually be, innervated via what we call the thoracoabdominal nerves. I'll show you those ones, actually from T7 to T11. Okay, as well as, of course, the subcostal nerve. Below, remember that in between any two ribs, there will be an intercostal space. So if a nerve is coming here, those ones represent the intercostal nerves. Okay, but below rib 12, because there's no, rib 13, then that nerve that will be coming from that area will be a subcostal nerve. So that's what, we have to know here. Okay, now remember that upon contraction of what we call the external oblique muscle, okay, it will help in actually compressing and, of course, supporting the abdominal viscera, okay, or organs. And it will also be important in flexing as well as rotating, of course, the trunk. So that's some important bits that we have to know. Now let me also show you some other muscle. Now if I cut the external oblique muscle and reflect it, the next muscle which will be deep to it, actually taking origin from the intermediate zone of the iliac crests, will be what we call the internal oblique muscle. Internal oblique muscle. Now look at the fibers of internal oblique. As external oblique muscle, is running this way, internal oblique muscle is running in opposite direction, and therefore the fibers, run perpendicular, to each other. Okay, so the fibers of external oblique and then of course fibers of internal oblique will run in a perpendicular manner, to each other. So remember that unlike external oblique muscle, which run actually inframedially, internal oblique will run actually, superomedially. Okay, running superiorly and of course towards the midline of the body, so superomedially. So this time around, unlike, yes, I've told you that it's only the external oblique which is going to have insertion on the iliac crest. The rest of the trilaminar muscles will have their origin. So by way of origin, from the anterior two-thirds of what we call the iliac crest, yes, will be taking origin from this area, will be the internal oblique. As well as, of course, now in the back area, okay, there is this thickened fascia which we call the thoracolumbar fascia. Thoracolumbar fascia. So thoracolumbar fascia will also provide some kind of origin to this, internal oblique muscle. Okay. And then, of course, there will also be some kind of, origin by way of some connective tissue that will be deep to the lateral aspect of the inguinal ligament. So these are the three main areas where, of course, the internal oblique will be taking origin from. Running superomedially to actually have some attachment to the rib. Now remember, all these trilaminar muscles will have some, attachment to the rib. So you have to take note of it. External oblique actually originated from the external surfaces of actually rib 5 to rib 12. But for internal oblique, it will rather be inserting there. So external oblique originated, internal oblique, yes, in an alternate manner, will actually insert actually to what we call the lower aspects, actually the lower aspects of what we call the inferior borders of, rib 10 to, 12, of rib 10 to 12, okay? Lower fibers of actually rib 10 to 12. That's how, the, internal oblique will actually be, inserting. I told you again that apart from that, yes, the linea alba is going to be a common insertion point for these, trilaminar muscles. Not only that, yes, we are also going to have what we call the pectin pubis. Now, when we talk about the pectin pubis, is the pectineal line, okay, is the pectineal line, okay, which, we find, in the pubis, okay, iliopectineal line. So the pectineal line or the pectin pubis will provide another, insertion point to, the internal oblique. But it will do that via a common tendon, which it will have with what we call the transversus abdominis muscle, which we call the inguinal falx, or the, conjoined tendon. Okay, so remember, by way of function, external oblique and internal oblique are, almost, going to have, the same function. So they're going to help, compress the abdominal content, hold them. Yes, apart from that, it's going to help, flex as well as rotating, the trunk. So, that's what we are saying. Now, this is the external oblique, okay, running inframedially, internal oblique running superomedially. Now, running transversely across the anterolateral abdominal wall area is this muscle. If I cut this internal oblique muscle and reflect it, taking attachment to the inner lip of what we call the anterior two-thirds of the iliac crest, will be the transversus abdominis. Now get to know the attachment of transversus abdominis and that of the internal oblique muscle are actually there's some kind of similarity in here. Okay, there's some kind of similarity in here. So it means taking origin from actually the iliac crest, actually anterior two-thirds of the iliac crest will be, of course, the external oblique, transversus abdominis muscle. Okay, now apart from that, the thickened fascia that I showed you over here will be the thoracolumbar fascia. Okay, now this time around, remember that we said that all these three muscles will have something to do with the rib. This one from the outer surfaces of actually rib 5 to 12, from the lower borders of rib 10, okay, 10 to 12 for internal oblique, okay, actually inserting, so origin inserting. Then this will also be origin. So origin for ribs, insertion for this internal oblique, Now, origin for transversus abdominis. So this time around is going to be actually the internal aspects. Remember, because this is the innermost trilaminar muscle, so it will be the internal aspect of actually rib 7 to 12. This time around, they are costal cartilages. Please get to know that this time around they are costal cartilages, okay, of rib 7 to 12, originating from this area. Okay, then I told you that yes, they are for origin, their attachment are going to be similar for internal oblique and of course transversus abdominis, and therefore again will be another origin will be the connective tissue that will be lateral. Sorry, connective tissue deep to the lateral aspect of the inguinal ligament. Okay, so by way of insertion, yes, as they run transversely, they will insert of course in the linea alba. Yes, apart from that, I told you that yes, also be actually inserting, they will have a common tendon. Okay, internal oblique and transversus abdominis will have a common tendon, that's the inguinal falx, or the conjoint tendon, to insert on what we call the pectin pubis, So these ones represent the main insertion point for what we call the transversus abdominis. But even apart from this, it also inserts on what we call the pubic crest. So pubic crest will be another insertion for the transversus abdominis muscle. So get to know that this transversus abdominis muscle, yes, just like the external oblique, internal oblique, yes, will also be supplied by the thoracoabdominal nerves, yes, from T7 to T12, to T11, as well as of course the T12 one being the subcostal nerve. But in addition, it will also be supplied by what we call the iliohypogastric and ilioinguinal nerves, L1. Now remember, internal oblique will also be supplied by that of L1. Okay, get to know that. But external oblique is not supplied by L1. Please get to know that. There will be a question which you have to look at this one. Okay, so these are it. Yes, of course, the transversus abdomen, because it's more closer to, of course, the viscera, it will help compress and of course support the abdominal viscera, as well as of course other content that may be there. Okay, so that is one thing that you have to know. But let me show you even this one. There's this muscle over here, being of course one of the muscles I've already shown you the surface anatomy, being of course the rectus abdominis muscle. Now the word rectus has to do with straight, and also of course the straight muscle of the abdomen. So rectus abdominis muscle, this is actually the right band of this rectus abdominis muscle that we are showing. And you can see the tendinous intersections over here. Okay, these whitish areas that you see, so that can help give this kind of 6-pack or 8-pack structure that you tend to find with some people. Okay, so for rectus abdominis muscle, this rectus abdominis muscle will be very important in actually flexing the trunk, as well as of course compressing the abdominal viscera. But importantly, look at it, it's actually originates from what we call the pubic symphysis, as well as the pubic crest, not the pubic tubercle, please. It's actually the pubic symphysis, okay, as well as the pubic crest, okay, of the pelvic region. Now over here, it's a bit this is the origin. This origin is a bit thicker, okay, compared to its insertion point. So it broadens, okay, and becomes less thick at its superior insertion attachment point, being the point of insertion. So it actually inserts on what we call the xiphoid process, okay, as well as the costal cartilages of actually rib 5. Okay, so from rib 5 to actually rib 7. So rib 5 to rib 7, okay, 5, 6, 7 will be the actually insertion point for this rectus abdominis muscle. So please get to know that. We actually see it. So this is actually a summary of what we've been talking about, the external oblique muscle. Yes, being innervated by the thoracoabdominal nerves. What I'm interested in telling you is that yes, the external oblique muscle is actually going to actually insert on what we call the anterior half of the iliac crest, actually the outer lip. So we can go through the rest. Now we talk about the rectus sheath. Now rectus sheath, that we talked about the anterolateral abdominal wall muscle, actually the aponeurosis, okay, the from the lateral aspect was fleshy. As we get towards, the midclavicular line and beyond, getting anteriorly, it becomes aponeurotic. Okay, that's the broad flat glycerin tendon. Okay, so this is what we are going to see. Now, from external, okay, now you can see there's a parietal peritoneum. As you go parietal peritoneum, you're going more internal. So here we are. This is the external aspect. We've reflected the skin, the superficial fascia. Of course, the endo-abdominal fascia being the transversalis fascia. We reflected all those ones. So we can see that now this muscle is therefore the external oblique muscle. Okay, external oblique muscle, and then it becomes aponeurotic, as you can see here. This is the internal oblique muscle, and this is the external oblique muscle. Now, the rectus sheath, which will contain this rectus abdominis muscle, the straight muscle of the abdomen, together with the pyramidalis muscle, okay, is going to be formed by the aponeurosis of these trilaminar muscles, these three muscles. So let's look at it. The rectus sheath will therefore have an anterior part, which we call the anterior rectus sheath, and it will have a posterior part, which we call the posterior rectus sheath. So the anterior rectus sheath will be formed by the aponeurosis of course, the external oblique muscle, as well as the anterior lamina, or the anterior part of what we call the internal oblique muscle, forming, of course, the anterior rectus sheath. Now, for the posterior rectus sheath, yes, it will be formed by, of course, the posterior half of what we call the, internal oblique muscle, its aponeurosis, as well as for the aponeurosis of what we call the transversus abdominis muscle. So get to know that, yes, in the midline over here, yes, there's that thickening of all these, the sheets to form, of course, the linear bulbar that we've talked about. Okay. However, yes, that's generally what we are going to see. But below the arcuate line, okay, the arcuate line is about a third from, the umbilicus to the pubic symphysis, or the pubic crest area. That's the arcuate line. Below the arcuate line, we don't have posterior rectus sheath. If you remember that, above the costal margin, we don't have posterior rectus sheath. So posterior rectus sheath is devoid, above the costal margin, as well as below the arcuate line. Now, below the arcuate line, you can see that this, posterior rectus sheath is devoid because of the skin, so we're getting more anterior. The anterior rectus sheath would therefore be formed by all the aponeurosis of all three, muscles of the anterolateral abdominal wall. Okay, so there's that of the aponeurosis of external oblique, that of internal oblique, that of the transversus abdominis muscle, will contribute to the formation of the anterior rectus sheath, and therefore the posterior rectus sheath will be deficient below the arcuate line. But let me tell you that, yes, by way of content of this rectus sheath, then it means that, yes, no doubt that rectus abdominis muscle will be a content. Apart from that, we also have what we call the, superior epigastric vessels, superior epigastric artery and vein, because, yes, those ones will run deep to what we call they run below what we call the, transversus, the rectus abdominis muscle. Even apart from that, we are going to have the inferior rectus, inferior epigastric vessels. Okay, so the same way, yes, that one also run in the rectus sheath. All right. Even apart from that, even the subcostal, nerve also run through the rectus sheath to even supply, the, pyramidalis muscle at a lower aspect. So then, apart from that, even the deep epigastric, vessels will also be content of this, rectus sheath. So, important bits that you have to know. Now, get to know, I've already been talking about the nerves of the anterolateral abdominal wall. Yes, being actually nerves which will be coming from the intercostal spaces. Okay, and therefore they are the intercostal nerves. But because they are going to work from the thorax to the abdomen, we also call them the thoraco-abdominal nerves. So these thoraco-abdominal nerves will give off, cutaneous sensation anteriorly, as well as, of course, sensation laterally. But let me tell you something, that these thoraco-abdominal nerves, okay, you can see that is from, the 7th one all the way to about the 11th one. Now below that, the 12th one is going to be the subcostal nerve. I told you that there's no, rib over there, the subcostal nerve. So remember that these nerves, I told you about it. We'll come to a question now. You get to know that the neurovascular plane, this is actually the surface anatomy I'm trying to show you, but it's actually going to be found between what we call the internal oblique muscle, as well as, of course, the transversus abdominis muscle. That will be the neurovascular plane, where we are going to have these nerves as well as blood vessels, which I'll show you. Okay, so let's see. Now, these ones from T7 to T11 will be the distal, okay, continuation of the 7 to 11th, intercostal nerves, because as they go through the ribs, they will be called intercostal nerves. But as they come this way, then we are referring to them as the thoracoabdominal nerves. So they are just continuing from where you have that, intercostal nerves. Okay, so actually, beyond this costal margin, then we are going to have, these thoracoabdominal nerves. Okay, now get to know they will run through. That's an important thing. They will run through what we call the neurovascular plane, and that is between the internal oblique muscle as well as, of course, the transversus abdominis muscle. Okay, and of course they will enter the subcutaneous tissue as the anterior branches. Okay, anterior branches, which of course they will give off these kind of cutaneous sensation, okay, to the anterior aspect, as well as cutaneous sensation to the lateral aspect. So please get to know these ones. Remember that they will be supplying these muscles importantly. Now, an important bit that we have to also know is that we also have this nerve. So these are the thoracoabdominal nerves. Just get to know that the subcostal nerve will be there. Now, there's this nerve. I'll show you. We'll take a closer look at it again. This nerve is the L1, ventral ramus of L1. And this nerve is actually having two branches, a superior branch, which you call the Iliohypogastric nerve, and an inferior branch, okay, running parallel to what we call the inguinal ligament, being the ilioinguinal nerve, okay. So these are two nerves, which you call them the L1 nerves, okay. These L1 nerves, okay, for instance, if you take the, Iliohypogastric nerve, okay, this iliohypogastric nerve will actually cross between the neurovascular plane. I don't need to tell you that's the internal oblique and transversus abdominis muscle, and then pierce the external oblique muscle, it's aponeurosis. Okay, that's what we are going to see. And of course the ilioinguinal nerves, this ilioinguinal nerve, yes, will actually be able to pass through what we call the neurovascular plane again, and of course get to the inguinal canal. Okay, so it will become a content of the inguinal canal. Later when we look at inguinal hernias, I'll explain the inguinal canal for you. Okay, so that is what we are going to see, but I'll show you something. Now get to know that even the iliohypogastric nerve is going to be actually a mixed nerve. I'll show you that. So talking about the neurovascular plane, we are not going to have only the nerves, but we also have what we call the blood supply, okay, to the anterolateral abdominal wall. So by way of this artery, which is the internal thoracic artery, which is actually one of the branches from the first part of the subclavian artery, will actually run deep to, of course, it will actually run deep to, of course, the costal cartilages, to actually give off these terminal branches. And these terminal branches, yes, one of them is here, being, of course, the musculophrenic artery. Okay, musculophrenic artery. Now remember, this musculophrenic artery, look at how it courses. It courses along the costal margin. This is the costal margin. So it courses along the costal margin, and it's distributed superficial as well as deep abdominal wall of the hypochondriac area. Okay, I'll show you the hypochondriac region, and then you get to know that. Of course, hypo means below, and chondriac has to do with cartilage. So below this costal cartilages, okay, all right. Now it also gives off this branch, which actually runs in the rectus sheath, and it actually runs deep to this muscle, which is the rectus abdominis muscle, and this is what we call the superior epigastric artery. The word epigastric has to do with above. Epi means above, and gastric has to do with the stomach, so above the stomach. This is the superior epigastric artery. Okay, so superior epigastric artery is also one of the contents of this rectus sheath, actually running deep to the rectus abdominis muscle. Okay, now what happens is that yes, it's actually distributed, to the rectus abdominis muscle, yes, superficial as well as deep abdominal, wall around the epigastric area. Okay, epigastric area, and even sometimes to the upper part of, the area where we have this umbilicus. Okay, all right. So that is what we see over here. But you can see that we are having this 10th as well as this 11th intercostal arteries. Okay, these intercostal arteries are actually direct branch from the aorta. Okay, the aorta. So they descend the aorta actually. So this 10th as well as of course the 11th costal cartilages as well as even the subcostal artery are actually branches of the the aorta, actually the abdominal aorta. Okay, so that's what we are going to see. Okay, and you can see as they are running somewhat inferiorly. Okay, from the superior aspect coming inferiorly and then reaching the anterior, from the lateral aspect reaching the anterior abdominal wall. Okay, and so what happens is that yes, they are going to supply the superficial and deep abdominal wall around the lumbar area. Okay, around where of course the flank or the lateral aspects of the body. Yes, similarly that's what the subcostal nerve artery is going to do. Then I want to actually show you this. Now the abdominal aorta, the descending abdominal aorta, this abdominal aorta will actually bifurcate at the level of L4. I will show you that when we look at the vasculature of the abdominal, of the abdomen. We look at that. So it actually bifurcates at the level of L4 to give us two arteries. And these arteries are of course the left and right common iliac artery, which of course also divide into of course internal and external iliac arteries. I'm interested in the external iliac artery. The external iliac artery, here is it, below. Okay, so after passing beneath this ligament, which is the inguinal ligament, modified aponeurosis of the external oblique, gives us this muscle, this artery, which we call the femoral nerve, to supply of course the anterior compartment of the thigh. Okay, so I'm interested in this artery. Okay, there's an artery over here, you can see this one. So this one, because it hasn't crossed the inguinal ligament, we are going to call it the external iliac artery. Okay, this one gives off this branch, which also runs deep to the rectus abdominis muscle in the rectus sheath, and this is what we call the inferior epigastric artery, inferior epigastric artery. So it tells you, yes, apart from even going to supply the area around the umbilical area, it's going to actually form an anastomotic connection with the superior epigastric artery. Okay, so it will supply even an area in the groin area, okay, as well. Okay, now even apart from that, there's another artery. Okay, now here is the artery, okay, running parallel but actually deep to what we call the inguinal ligament, is what we call the deep circumflex iliac artery. So the name tells you why we are calling it deep, because it's running deep to this ligament over here, which we call the inguinal ligament. So this artery, which is also a branch of the external iliac artery, is what we call the deep circumflex iliac artery, deep circumflex iliac artery. Okay, so I don't need to tell you that yes, even the deep circumflex iliac artery, yes, will be important in supplying of course the iliacus muscle. I'll show you the iliacus muscle in the iliac fossa. Okay, so that's what we are actually going to see. Now even apart from that, now below this inguinal ligament, we are going to have the femoral artery. The name of the artery has changed from common iliac artery, external iliac artery, to femoral artery, and it gives off this artery. Okay, so let me show you this artery, because it's running external or outer to what we call the inguinal ligament. We are going to call it superficial epigastric, superficial circumflex iliac artery, superficial circumflex iliac artery. So the superficial circumflex iliac artery, it means it's a branch of the femoral artery, also running parallel to the inguinal ligament, but actually superficial or external to it. Okay, And then, what it means is that it's going to supply, the superficial abdominal wall around the inguinal, area, as well as, this region, superior aspect of, the thigh. Then there's also another artery which, running superficial, running on top of this, inguinal ligament. So running superficially, and therefore we call this one superficial epigastric artery, superficial epigastric artery. Okay, superficial epigastric, artery. Okay, so this superficial epigastric artery will actually run in the subcutaneous tissue, towards where we have the umbilicus, so the umbilical area. So I don't need to tell you that it's going to, help supply the superficial area, the skin, of course, and the subcutaneous tissue, around where we have the umbilicus. Okay, so that's what we are going to see. All right. Now let's go to question number 2. And question number 2 says, which of the following is not true? Now option A says, above the umbilicus, the anterolateral abdominal wall drains mainly into the axillary group of lymph nodes. Now this is a very true statement. This is a very true statement that above the umbilicus, yes, the anterolateral abdominal wall drains into what we call the axillary group of lymph nodes, although some small amount actually gets to what we call the parasternal nodes. Remember that below the umbilicus, then of course it's going to be the superficial inguinal lymph nodes. And of course for the deep, it's going to go to what we call, the para-aortic, the paracaval or the lumbar, lymph nodes, as well as of course, the common, of course, internal iliac group of lymph nodes. So we look at that. Now option B says neurovascular plane of the anterolateral abdominal wall is found between the internal oblique muscle and the transversus abdominis muscle. I've said this times without number, so that's a very true statement. Option C says, unlike the superficial boundary of the abdomen being the diaphragm, the inferior boundary is not physical and thus continuous with the pelvis. Yes, of course, we know that the thoracic cavity is separated from the abdominal cavity by, of course, the thoraco-abdominal diaphragm. Okay, but you get to know that the inferior aspect between, of course, the abdomen and the pelvis, there's no physical boundary. But imaginally, we know that, of course, the pelvic brim will tend to, separate them. But so therefore, they are continuous. That's why we tend to say abdominal pelvic, cavity or anything like that. Option D says, for better cosmetic effect, it is recommended to make abdominal incisions parallel to cleavage lines. So these cleavage lines, also known as Langer lines, yes, are very important if you want to have, faster, wound healing, where there's little or no scar formation. Then of course, if you go through these incisions along or parallel to what we call the cleavage lines of Langer lines, then that is what we are going to see. That's a very true statement. Option E says the rectus abdominis muscle is thicker at its inferior origin but broader at its insertion point. That's a very true statement. I've already said that to you. So there we are. Now the superficial part, now look at it. This is the umbilicus. Now above, the region above the umbilicus, okay, will drain into what we call the axillary group of lymph nodes mainly, with few getting to the parasternal group of lymph nodes. Okay, but below the umbilicus, superficially, it will drain into the superficial group of lymph nodes. Superficial group of lymph nodes. Okay, now let me actually show you this. Now get to know that yes, if I take off the skin, now you can see there's a subcutaneous tissue or superficial fascia. Now you can see that we have a branch of the axillary vein, being of course the lateral thoracic vein, lateral thoracic vein. And of course we have a branch of the femoral vein, a tributary of the femoral vein being the superficial epigastric vein. They tend to form this anastomotic connection. So subcutaneously you can see that, and that is what we call the thoraco-epigastric vein. So thoraco-epigastric vein is nothing but an anastomotic connection between the superficial epigastric vein, which is a tributary of femoral vein, and of course lateral thoracic vein, a tributary of the axillary vein. So I don't need to tell you the deep lymphatic drainage of the anterolateral abdominal wall will be to the, of course, the caval, paracaval, or para-aortic or aortic, and then of course, to of course the lumbar, if you want to call lumbar, as well as of course, the common iliac as well as of course the external iliac. So I told you that yes, by way of limit, there is the thoracic cavity, there is the abdominal cavity. The thoracic cavity is separated from the abdominal cavity by this diaphragm. The pelvic cavity and the abdominal cavity are more or less continuous. That's why we use the word abdominal pelvic cavity. But imaginarily, we can use the pelvic brim, to demarcate that. Okay, so that's what we have to know. But for surface anatomy by way of wall, then what you have to know is that if you talk about, of course, the inferior boundary, okay, at the lower aspect, then you should be thinking of course, the iliac crest. Talk about the anterior superior iliac spine together with the, ligament, the inguinal ligaments over here, as well of course, so that's what iliac crest as well. Okay, so these ones represent the inferior boundary, even the pubic symphysis as well. Okay, then the superior boundary will be by the diaphragm. Okay, by the diaphragm in there, and then of course, centrally the landmark over there is the umbilicus, which you know already. Okay, now let me just give you this information. Now sometimes there could be abdominal distension, or there could be a question that you should tell the 6 F's or whatever F's that you can find in the abdomen. So mainly those things will cause distension of the abdomen, and these are of course fat. Okay, if you build a lot of fat in the campus fascia, okay, then the abdomen becomes distended. Yes, it could be fluid, could be acidic fluid, whatever. Then it could be flatus, okay, in there. It could be fecal matter, it could be fetus, it could be food, and then it could be a fatal cancer or fulminant tumor or neoplasia. Okay, so those ones will be the 6 F's, whatever F's that you can find in the abdomen, and these things are able to cause distension of the abdomen. So I told you that yes, we have Langer lines or cleavage lines. Okay, and these cleavage lines, yes, as you see, they correspond to the natural orientation of collagen fibers in, of course, the connective tissue dermis, okay, of the skin. Okay, so if you're able to cut along where we have the Langer lines, okay, then surgically these incisions will actually form less scar. Okay, so that's what we see, and then it also promotes faster healing. Okay, so these are the Langer lines. Now for abdominal incisions, please get to know, yes, I'm going to tell you major ones. Yes, like this one being the Quadratus incision or the subcostal incision, actually the right subcostal incision. Okay, this one over here. And usually if you want to look at the biliary tree, that's where you go in there. Or if you want to perform some surgery on what we call the the bile, the gallbladder, that's where you go through. Okay, that's where you go through. So that's it. But if you do it at the left subcostal area, or if it's a left subcostal incision, then that one, yes, you are more interested in looking at the spleen, for instance. Then of course we also have what you call the vertical or the midline incision. Now for the median incision or the midline incision, yes, you go through it, okay, vertically, but this time where you cut up along. Okay, you don't cut through the umbilicus, you cut around the umbilicus. Okay, and that is if you want to do a generalized surgery in the abdominal cavity. So for laparotomy, okay, where you want to open up the abdomen, that's when you go through. But even nowadays they do micro surgery, such that small incisions are made in there, and that's what you call laparoscopy actually. So parallel to that, but if not going through the midline, then we're going to call it paramedian incision. Okay, paramedian incision. Then of course you can have a transverse incision. Whatever organ that you want to go into the abdomen, you can go through that one. Then now around this area, okay, around the groin area, actually, yes, the right side, we are going to have where we have the appendix. So if you want to do appendicectomy, then you have to go through this incision, which we call the Magbenis plane. Magbenis plane. So that's what we are going to see. Yes, other incisions that you can see, Yes, if you look at this number 9, that's the phalansteal incision. Okay, so that's one you have to just know their names actually. Then for the opposite aspect, if we are not going through, we are not going for the appendix, for instance, and we are going to the opposite aspect, actually the left part, then that is the Rutherford-Morrison incision. Rutherford-Morrison incision. So these are some abdominal incisions that of course we have to know. Now for the the rectus abdominis muscle, I told you, yes, it's going to actually originate from the pubic crest as well as of course the pubic symphysis, not the pubic tubercle, okay, inferiorly, where it is a bit thicker and narrower compared to its insertion point, where it flattens, becomes broad, and of course inserts in what we call the the xiphoid process, as well as of course the costal cartilages of rib 5 to actually rib 7. Okay, so that's what we are going to see. This is the, and you can see these are, this is the rectus abdominis muscle. These are the tendinous intersections that you find here. Now let's go to question number 3, and question number 3 says, which of the following is not true? A, the fibers of the diaphragm insert in its central tendon. This is a very true statement. You see that the diaphragm will have vast origin, but they will all come together to insert in a common tendon, which we call the central tendon of the diaphragm. Option B said during inhalation, the diaphragm contracts and moves upwards. Now, during inhalation, yes, it's true that the dome shape of the diaphragm actually contracts and assumes a flat shape, but it doesn't move down. It doesn't move upwards. It actually moves down. The reason is that, yes, it has to move down so that the the thoracic cavity could actually be, have enough room for more air to come in. So I'll show you. Now, so that's actually a wrong statement. Now option C says the medial and lateral aqueous ligament overlie the psoas major muscle and quadratus lumborum muscle respectively. This is a very true statement. I'll show you. Now option D says blood supply to the diaphragm comes from the superior and inferior phrenic arteries, which are branches of the descending thoracoabdominal aorta. Yes, I'll show you that, yes, the inferior portion of the thoracic aorta will give rise to, of course, the superior phrenic artery. Then below that, just below the diaphragm, it will give off the inferior phrenic artery, and they are going to supply the diaphragm. Option E says viscera that are related. So this one is supposed to be viscerae. We're supposed to add E to it. Viscerae that are related to the kidney inferiorly include the liver, stomach, spleen, and the kidneys. Yes, this is a very true statement, which are related to, actually is the diaphragm. Sorry about that. This is supposed to be the diaphragm. So that's a very true statement. I'll show you. So there we are. We have the the diaphragm. Diaphragm will have vast origin, actually originating from the xiphoid process of the sternum. Okay, actually originating from the lower six ribs actually. Okay, we have 12 pairs of ribs. The lower 6 ribs will give origin to the diaphragm, even the lumbar area, okay, by way of these aqueous ligaments. This, of course, I'll show you again. This is the medial aqueous ligament. This is the lateral aqueous ligament. Okay, I'll show you that. But eventually, they all converge in here to insert on this white area that you find here. This is the central tendon of the diaphragm. Now, during inhalation, that's breathing in or inspiration. Yes, when you look at respiratory system again, I will show you that one. But remember that essentially, an important muscle which we need it to contract will be the diaphragm under the influence of the phrenic nerve. Okay, then it contracts. When it contracts, then look at it. It contracts. Originally it is having this dome shape. When it contracts, it moves downwards so that the thoracic cavity could actually be large enough to accommodate air that is coming in. So that's all I want to show you. Okay, so I will show you the rest later. But by way of telling you some functions of the diaphragm, the diaphragm is very important for inspiration, okay, breathing in, very important. The diaphragm, yes, upon contraction, what will happen is that as abdominal cavity is having an increased volume, then it means the pressure over there has decreased, but it compresses on what we call the abdominal organs, and therefore increasing the intra-abdominal pressure, because the volume in the abdomen will be reduced. Okay, so that we increase the abdominal pressure for micturition, defecation, parturition, and what have you. Now again, yes, for instance, if the same way, if the diaphragm contracts, then what happens is that yes, we're able to push on the abdominal viscera to help in, of course, increasing intra-abdominal pressure for weight lifting actually. Then of course, thoracoabdominal pump. One important thing is that yes, the diaphragm, as it descends by way of contracting, it decreases intrathoracic pressure. That's very true, but increases intra-abdominal pressure, because as it pushes on the abdominal viscera, what happens is that the space over there decreases. Okay, so when the volume decreases, then it means pressure goes up. From Boyle's law, you can get that relation. Then when that happens, this compresses the blood in the inferior vena cava. So it's serving as, helping, bring up, blood to the heart through, of course, the inferior vena cava, against gravity. Okay, that's one important thing, together with, of course, the lymphatic, vessels in there. So talking about the aqueous ligament, there are 3 aqueous ligaments. Okay, now the diaphragm is having crura, is having leg-like processes. So we are going to have the right cruce of the diaphragm. We are also going to have the left cruce of the diaphragm. In between them, connected, will be what we call the median aqueous ligament. Median aqueous ligament. So connecting, of course, the right cruce and the left cruce will be the median aqueous ligament. And then overlying, overlying what we call the psoas major muscle, we get to see that is what we call the the medial aqueous ligament. Medial aqueous ligament. Now these aqueous ligaments are thickened fascia. Okay, thickened fascia, and of course overlying this 4-sided muscle, the Quadratus Lumbora muscle, is the lateral aqueous ligament. Lateral aqueous ligament. So that's one thing that you have to see. It's a very true statement. Now, by way of relations, okay, the diaphragm will be related inferiorly to the liver. Apart from that, even the kidneys, okay, and then of course even the stomach will be related there. Okay, even the spleen will be related to, of course, the diaphragm, inferiorly. So that's one thing. Of course, superiorly, we are going to have, of course, the heart being there, as well as even the inferior aspect of the lungs. Okay, the diaphragmatic surfaces. Now let me show you that we have 3 main openings in the abdomen, and there are other things which go through, which you have to know. So there are some structures which will have to leave the thoracic cavity and enter the abdominal cavity, or there are some structures which will have to leave the abdominal cavity and enter the thoracic cavity, and therefore they will have to go through some apertures, okay, or some openings in the diaphragm, because the diaphragm is serving as a physical barrier over there. Okay, so these ones, okay, for you to know that yes, one of them, the question was actually talking about those esophageal hiatus. Okay, esophageal opening. So let me just tell you this. Now over here, there's esophagus. Now if you spell esophagus, okay, O-E-S-O-P-H, okay, A-G-U-S. Now you realize that you are going to have what we call a 10-letter word. Okay, so esophagus, spelling esophagus, okay, by British way, then are going to have, it's going to be a 10-letter word. Now if it is a 10-letter word, then it means the hiatus of the diaphragm, which the esophagus will go through, being the esophageal hiatus, will be at the level of T10 vertebral level. T10 vertebral level. Okay, not only are we going to find the esophagus, but in addition we have, of course, the anterior and posterior vagal trunks. Okay, Apart from that, we are going to have what you call the phrenico, abdominal branch of the left phrenic nerve, the esophageal branch of the left gastric artery, of course, then esophageal, tributaries of the left gastric vein. When you look at, of course, the vasculature of the, abdomen, I'll show you. Now, the next one is the caval opening. Now, if you spell vena cava, 4 letter together, giving us 8. So it will be at the level of T8 vertebral level. The caval opening will be at the level of T8 vertebral level, but it is not only the vena cava or the inferior vena cava, superior vena cava is running through it. Okay, inferior vena cava, but in addition, it will also be moving together with, of course, the right, phrenic nerve. Okay, right phrenic nerve. Then the next opening, which is over here, will be the, that of the aorta, the aortic, opening, or the aortic hiatus. Now, if you put these two words together, then we are going to get a 12-letter word. So if it is a 12-letter word, then of course it means that the aortic opening will be at the level of T12 vertebral level. Not only are we having the aorta, but the azygos and hemiazygos veins, or the azygos system of veins, will go through that, the thoracic duct, as well as, of course, the aortic, plexus, But mainly, AAT will go through the aorta, azygos and hemiazygos system, and of course, thoracic duct. Now let's go to question number 4, and question number 4 says, which of the following is false? Now, option A says the Quadratus Lumborum is a muscle of the posterior abdominal wall, and it sits on the iliac crest, Yes, that's a very true statement. You get to see the Quadratus Lumborum, that four-sided, muscle. Now, option B says the Quadratus Lumborum muscle is supplied by the lumbar arteries, okay, and the spinal nerves of T12, as well as L1 to L4 nerves. That's also a very true statement. I'll show you. The psoas major muscle originates from the body's transverse processes, as well as, of course, the adjoining intervertebral disc of T12 to L4. That's also a very true statement. Now, option D says the lower fibers of the psoas major muscle receive blood from branches of the femoral artery. This is a very true statement. Yes, because we know that even the femoral psoas major muscle could be considered part of what we call the muscles of the anterior compartment of the thigh, and therefore the muscles of the anterior compartment of the thigh are supplied by the femoral nerve. So of course, it's not surprising that the lower fibers of the psoas major muscle will be supplied by the femoral nerve. Now, option E says the psoas major muscle covered by the psoas fascia is supplied by the ventral rami of L1 to L4, as well as, of course, the iliolumbar branch of internal iliac artery. That's actually a very true statement. So let me justify them. So here we are. This is the Quadratus Lumborum muscle, this four-sided muscle, and this four-sided muscle, yes, actually originates from, of course, the posterior iliac crest. Now, get to know, let me see what the question was about. So the question was talking about, inserting on the iliac crest. So this makes it wrong. Because the fibers actually move, superomedially. So it actually originates from that side. So it originates from the iliac crest, okay? Because I told you that any other muscle apart from the external oblique muscle, okay, having some attachment to the iliac crest will actually be originating there, except external oblique. It's only external oblique muscle which will be inserting there. So it's actually going to originate here, and of course moving superomedially to have attachment to the lower aspect of rib 12, as well as, of course, the transverse processes of actually rib 12, as well as, of course, L1 to L4. Okay, L1 to L4. So that's one thing that you have to know. So remember that if only one side contracts, then it laterally tilts the pelvis. And again, it laterally flexes the vertebral column to the same side. Okay, and to also assist the vertebral column. Okay, to extend actually the vertebral column. Okay, but bilaterally both of them contracts at the same time, then it helps fix these ribs actually during inspiration as well as expiration. During forced breathing, then you can actually help in fixing these ones. So I told you, yes, it will be supplied by, of course, T12, L1 to actually L3 nerves. So get to know that here now there's the abdominal aorta. You can see that it's going to have there's the inferior phrenic artery actually coming out. Then you are going to have it's actually bilaterally spread. You're going to have, of course, these kind of arteries, even apart from having this artery being, of course, the suprarenal artery. Okay, we are also going to have, of course, the renal artery on the other side, the gonadal ones. We will see these ones later, but importantly, I'm interested in the lumbar arteries. The lumbar arteries will actually supply the quadratus lumborum muscle. We will get to know later that the ventral branches of the abdominal aorta will be the celiac trunk or the celiac axis, superior mesenteric artery, and of course inferior mesenteric artery. We will look at these ones. Okay, so we have 4 paired lumbar arteries. Okay, 4 paired lumbar arteries. Okay, 1, 2, 3, and then 4 paired lumbar arteries actually supplying what we call the quadratus lumborum muscle. So there we are. This muscle is the psoas major muscle. At its inferior aspect combines with the iliacus muscle to form a compound tendon to insert in what we call the lesser trochanter. So this psoas major muscle, yes, will actually be supplied by what we call the ventral rami of L1 to L4. Please get to know that. Okay, and of course the iliolumbar branch of what we call the internal oblique. Internal iliac artery. So this is actually the psoas major muscle. Now let's go to question number 5, and question number 5 is the last question. It says, which of the following is not true? Now option A says running lateral to the psoas major muscle is the obturator nerve. This is a wrong statement. The reason is that yes, running rather medial to the obturator psoas major muscle will be the obturator nerve. Running lateral will actually be, of course, the femoral nerve. I'll show you the rest of the nerves. Option B says with respect to the psoas major muscle, the medial most structure is the sympathetic chain. Yeah, this is also a very true statement. I'll show you the structures that we have. Now option C says the psoas minor muscle present in about 80% of the population originates from the T12 to L1. Yes, T12 and L1 vertebrae, as well as, of course, the intervertebral disc between them, and inserts on the iliopubic eminence, on the pectineal line. Okay, and then of course it is actually innervated by L1 spinal nerve. That's also a very true statement. The psoas major muscle will be absent in about 20% of the population. Please get to know that. Okay, psoas minor will actually originate from, it's actually going to be the the bodies. Okay, bodies. This time around no transverse process, because that one is a bit superficial, so no transverse process, but the bodies only. Now option D says the iliacus muscle forms a common tendon with the psoas major muscle inferiorly to insert on the lesser trochanter of the femur. Yes, that's a very true statement. Option E says the iliohypogastric nerve supplies all the 3 flat anterolateral muscles, with subcostal nerve supplying the pyramidalis muscle. Now this statement is actually a false statement. The reason is that yes, the iliohypogastric nerve, although we know it's a mixed nerve supplying some portion of the gluteal region, but we know that yes, it will supply only 2 of the 3 flat muscles, not the external oblique, if you remember. So the internal oblique as well as transversus abdominis muscle, not all the 3, will be supplied by the iliohypogastric nerve. And of course, the subcostal nerve will go through the rectus sheath to supply, of course, the pyramidalis muscle. No waste about that. So here we are. This muscle, 4-sided muscle, is the quadratus lumborum muscle. Okay, medial to it is a psoas major muscle. Now this psoas major muscle is having important relations which you have to know. Now, running on the medial aspect of the psoas major muscle, you can see this nerve that is coming out. This nerve is known as the obturator nerve. This is the obturator nerve, okay, running medial to the psoas major muscle. Now, piercing the psoas major muscle, okay, is actually what we call the genital femoral nerve. Okay, genital femoral nerve, actually with root values L1 to L2. This genital femoral nerve will actually divide into two to give us, this branch, which goes to, of course, the genitals to supply actually the cremasteric muscle, and that's why it's very important in the cremasteric reflex. Now, the lateral branch actually gets to the femoral area to supply the skin around the femoral area, gives it some continuous supply. Actually, around where we have what we call the femoral triangle, the skin around the femoral triangle is going to give it some continuous sensation over there. Now, so get to know the genital femoral nerve actually pierces through the psoas major muscle. Now, look at this. Here we have this nerve, which actually is running medial to this psoas major muscle, and this nerve is the femoral nerve. Lateral to the psoas major muscle is the femoral nerve. Okay, so once you have your muscle over there, psoas major muscle running lateral to it will be, of course, the femoral nerve, L2 to L4, of course. For obturator nerve, that one to L2 to L4, root values again. Now, you get to know that, again, another way that you can, figure this out is that this muscle over there is the iliac muscle. So it means the femoral nerve is somewhere between the psoas major muscle and the iliac muscle. Yes, you can get that one to see. Again, we can see this nerve coming actually from the lumbar plexus. Okay, this nerve is actually the lateral femoral cutaneous nerve of the thigh. Lateral cutaneous nerve of the thigh. Okay, so of course you can also call lateral femoral cutaneous nerve. So there's a lateral cutaneous nerve of thigh. Okay, this is coming from the lumbar plexus. So it tells us that the medial and the intermediate cutaneous nerves of thigh will actually be coming from the femoral nerve. Okay, get to know that. Okay, so this one will actually, yes, also lateral, but it will be coming a bit superior to what we call the femoral nerve. That's what we are going to find. Okay, that's what we are going to find. So you can see the subcostal nerve, and then of course the iliohypogastric being the superior one, ilioinguinal being a bit inferior. No two ways about that. We will see the rest. But by way of just looking at the psoas major muscle, okay, if this is the vertebral column, then what happens is that just paravertebral, then you are going to have the sympathetic chain. So from medial to lateral, yes, sympathetic chain, followed by, of course, the lumbosacral trunk, then followed by, of course, the iliolumbar artery, as well as, of course, the obturator nerve. Although we know the obturator nerve will be medial, but it will be just medial to the psoas major muscle. But the medial most structure from the paravertebral region will be, of course, the sympathetic chain. So there we are. We have the psoas minor muscle. Okay, psoas minor muscle, actually from T12L1, as well as, of course, the intervertebral disc between them, and of course inserting on the iliopubic eminence, okay, around here. This is the psoas minor muscle, which is absent in about 20% of the population. Okay, remember that functionally is going to be a weak flexor of the trunk. So this is the common tendon of the iliac muscle. This is the psoas major muscle, inguinal ligaments. This is the Quadratus Lumbora. Iliac muscle from the iliac fossa, psoas major muscle, okay, who actually inserts on the lesser trochanter via a common tendon, which you call the iliopsoas tendon. Yes, let me show you something again. Here we are. Here we can see iliacus muscle, the psoas major muscle, okay, running lateral to it. In between, of course, the iliacus and psoas major muscle will be the femoral nerve, but running on the medial aspect will be, of course, the obturator nerve. Then above this femoral nerve will be, of course, the lateral cutaneous nerve of thigh, okay. And then we also have, of course, the subcostal nerve. Okay, you can see that the subcostal nerve is actually supplying. Now look at this subcostal nerve. Yes, even will be supplying. You can see the transversus abdominis muscle. Yes, even apart from that, you will see there's the internal oblique muscle, and of course there's the external oblique muscle. It's not really supplying much of the external oblique muscle, okay, so we can even take this one out. But essentially, to go through the rectus sheath to supply the lower aspect of the content of the rectus sheath being the pyramidalis muscle, okay. Then this nerve being, of course, actually coming from the ventral ramus of L1 level, is what we call it's going to divide into two: a superior branch, which we call it the Iliohypogastric Nerve, and an inferior branch, which we call the Ilioinguinal Nerve. Now look at it. They are both, supplying, the transversus abdominis and, of course, the internal oblique, not the external oblique muscle. Not the external oblique muscle. So remember that the Iliohypogastric nerve, yes, we know that it's a mixed nerve. Yes, it's going to actually, supply the skin on the, anterosuperior aspect, anterosuperior aspect of the quadrant, anterosuperior quadrant of the gluteal region. Apart from that, it will supply, of course, transversus abdominis and an internal oblique as trilaminar muscles, as the flat muscles of the anterolateral abdominal wall, except the external oblique muscle. So I hope you find this tutorial quite helpful. We will do the other bits in our later section. Have a good night, and may God richly bless you.